Okay, let's jump right into the material. Today, we are doing a deep dive into cephalosporins, which are, they're arguably one of the most important and widely used classes of antibiotics in the world.
Oh, absolutely. They are foundational medicine. Cephalosporins are generally bactericidal, so they're directly killing the bacteria,
Oh,
and they work against this just a remarkably broad range of organisms, both gram-positive and gram-negative.
and this is the thing, for anyone studying or practicing medicine, the complexity is just immense. We've got sources here that lay out this entire tiered generation system, and each one has its own profile, its own targets, its own list of, critical warnings. It's a lot to keep in your head.
It is. So our mission today is really clarity. We're going to try and simplify the pharmacokinetics, how the drug moves through you. We'll map out that generation system. And I think most importantly, we're going to isolate those crucial safety warnings because that's where a nuanced understanding is just essential.
Okay, so let's unpack that and start with the drug's journey. When these compounds go into the body, how well do they actually get around? Where do they go?
Generally, they penetrate quite well. They diffuse really effectively into most body fluids and the extracellular fluid of most tissues. But what's really fascinating is that the body often helps the drug along during an infection.
How so?
Well, if there's active inflammation, that process actually increases the permeability of the blood vessels, which in turn enhances the diffusion of the cephalosporin right into that tissue. So it's a very effective mechanism.
So the site of the infection actually becomes more open to the drug? That makes sense. But are there places where they just struggled to get to?
Yes, there are a couple of key areas they penetrate poorly. One is intracellular fluid, which is a big deal if you're fighting intracellular pathogens, and the other is the vitreous humor of the eye. But the most critical barrier by far is the blood-brain barrier.
Right, getting into the central nervous system, the CSF.
Exactly. And this is a vital distinction because, if you're trying to treat a life-threatening infection like meningitis and you choose the wrong cephalosporin,
The drug just won't get there.
it simply won't. The vast majority of them can't reach the concentrations you need. However, there are 4 exceptions. 4 specific drugs that can crack that CNS code and treat meningitis effectively.
And those 4 are absolutely critical to know. Which ones are they?
They are ceftriaxone, cefotaxime, ceftazidime, and cefepime. Just those 4. They have the right structural adaptations. It's often related to their lipophilicity or specific transport mechanisms that let them cross into the CSF in high enough levels to be useful.
That one piece of information could be the difference between life and death. Okay, so moving from penetration to elimination. How does the body get rid of these drugs?
For the most part, as a class, they're primarily excreted unchanged in the urine. That's the general rule.
And that means dose adjustments.
It means for any patient with renal insufficiency, with impaired kidney function, you absolutely have to adjust the dosage downward to prevent the drug from building up to toxic levels.
But there are always those crucial exceptions, the ones that make life easier in complex patients. Which ones break that rule?
The essential exceptions here are cephalosporin and ceftriaxone. These 2 have significant biliary excretion. They're cleared through the bile duct and into the stool.
So the big clinical takeaway is what?
That these 2 drugs uniquely do not require a renal dose adjustment, and that single detail makes them invaluable when you're dealing with severe renal impairment.
That's a perfect segue into the core identity of this whole class,
Yeah.
the generation map. The entire system is built on these structural tweaks to hit different bugs. So what's the fundamental trend as we go from, say, generation 1 to 4?
The general principle is that as you move up to the higher generations, you progressively expand the spectrum of activity, specifically against aerobic gram-negative bacilli. The higher you go, the better they generally get at handling things like E. coli or Klebsiella.
Okay, but before we get into the strengths, let's define the boundaries first. What are the universal pathogens that cephalosporins as a class just don't touch?
That is the most important place to start. Regardless of generation, they generally lack reliable activity against 3 major groups. First, Enterococci.
Okay.
Second, most methicillin-resistant Staphylococci, or MRSA, though we will get to the big exceptions there in a minute. And third, most anaerobic gram-negative bacilli. If you see those on a culture report, you should probably be thinking about a different antibiotic class.
Got it. So let's start at the beginning with the first generation. Where do they really shine?
Their core strength is excellent activity against gram-positive Cocci.
So clinically, what does that look like? Where do we see them used?
Well, orally, they're great for uncomplicated skin and soft tissue infections, the ones caused by staph and strep. And then parenterally, the drug cefazolin is just a workhorse. It's used for endocarditis from methicillin-sensitive S. aureus, and it's the absolute mainstay for surgical prophylaxis cardiothoracic, orthopedic, abdominal surgeries.
Okay, moving to the second generation. This is where we start to see that shift in spectrum.
Yep. They're a little less potent against those gram-positive cocci than the first gen, but they start to pick up some activity against certain gram-negative bacilli.
And we often hear about cephamycins being grouped in here. What's the story with them?
Right, the cephamycins, so that's drugs like cefoxitin or cefotitin, they were historically really useful because they had better activity against anaerobes, including a really important one called Bacteroides fragilis. So they were used for mixed infections, especially in the abdomen.
But I remember seeing a pretty stark warning in our source material about that. Why the caution now with intra-abdominal infections?
And this really highlights why you have to stay current. Despite that historical reputation, Bacteroid strains are just not reliably susceptible to cephamycins anymore in many places. The resistance patterns have shifted.
So they're not recommended for that use.
Not for empiric use, no. Relying on those old habits can lead straight to treatment failure. It's a classic example of the arms race against bacteria.
That's a great point. Okay, let's broaden our horizons with the third generation. This is where the class gets really expansive, right?
Absolutely. Third-gen agents hit crucial pathogens like Haemophilus influenza and most of those core gram-negatives we call Enterobacterella. So think E. coli, Klebsiella pneumonia, Proteus mirabilis.
But there's a massive caveat there, isn't there? It only works if the bacteria haven't developed certain defenses.
That is the critical filter. They work great as long as those bacteria don't produce ESBL or AMPC beta-lactamase enzymes. Those are the molecular scissors the bacteria use to just chop up the antibiotic.
And within the third generation, there's also the Pseudomonas divide. Not all of them cover that bug.
That's right. Only 2 third-generation drugs are active against Pseudomonas aeruginosa, ceftazidime and cefaprazone. The rest of them miss it completely. And with ceftazidime, there's an interesting trade-off.
Which is?
Well, while it gives you that Pseudomonas coverage, it has really poor activity against gram-positive species on its own. You would never use it for a simple staph infection.
But now we see it combined with other drugs.
Yes, very often with avibactam. Adding avibactam, which is a beta-lactamase inhibitor, is a huge upgrade. It massively broadens the spectrum to include some of those really resistant enterobacteriales that produce AMPC, ESBL, and even KPC enzymes.
Which takes us to the fourth generation, and the main player there is cefepime. What's the advantage it brings to the table?
Cefepime offers enhanced potency against gram-negative bacilli. It has reliable activity against P. echinopsa, so it's on par with ceftazidime there. But importantly, it also works against some of those AMC-producing bugs, like Enterobacter, which makes it a step up. Its gram-positive activity is pretty similar to cefotaxime.
Okay, now let's shift to the true resistance fighters, the specialized, newer agents designed to solve the problems the older generations can't. Let's start with the drugs that finally crack that MRSA problem.
Right. These are often unofficially called the fifth generation, ceftaroline and ceftobiprole. Their big innovation is a structural change that allows them to be active against methicillin-resistant S. aureus, MRSA, and also penicillin-resistant strep. They finally fixed that core limitation of the whole class.
That's a massive clinical gain. But is there a trade-off? Do they lose any of that gram-negative coverage?
For the most part, no. Their activity against other gram-positives and gram-negatives is pretty similar to the third-generation drugs. But, and this is a critical limitation you have to remember, neither ceftaroline nor ceftobiprole is active against Pseudomonas.
So you gain MRSA coverage, but you lose Pseudomonas coverage.
Exactly. You'd still need a different agent if Pseudomonas is your target.
Then we have cefiderocol. This one uses a really unique mechanism, almost like a Trojan horse.
It is genuinely novel. Cefiderocol is a Cider-4 cephalosporin. It basically latches onto the bacteria's own iron uptake system to sneak itself across the outer membrane, bypassing a lot of common resistance mechanisms. It's so powerful that it's typically reserved for definitive therapy of very serious invasive infections.
And which superbugs is it designed to kill?
It targets the absolute toughest gram-negatives out there. P. aeruginosa, Acinetobacter baumannii, Stenotrophomonas multifida, and those enteric bacteria producing the worst of the resistance enzymes, ESBLs, KPCs, and even MBLs, the metallo-beta-lactamases.
Wow. So given how specialized it is for gram-negatives, what does it lose?
It's a very sharp tool for a specific job. It has no reliable activity against gram-positive bacteria or any anaerobes.
And finally, in this group, we have ceftolozane tazobactam.
Right. This combination is prized primarily for its extremely powerful activity against multi-drug-resistant P. aeruginosa. The tazobactam also protects it, so it works against most enteric gram-negatives, strep, and some anaerobes, even some of the ESBL or MPC producers.
That covers an immense amount of ground. But now we have to shift gears and talk safety, because these drugs, as effective as they are, carry some really critical risks.
Yes. Starting with the most common issue, hypersensitivity reactions. This is what you'll see most often. Usually it's a rash. The really scary immediate IgE-mediated anaphylaxis is thankfully pretty rare.
And we also see the classic antibiotic problem of a secondary infection.
We do. Like a lot of broad-spectrum antibiotics, they can disrupt the normal gut flora, which can lead to clostridioids, difficile-induced diarrhea, or C. diff. And other big effects can include blood abnormalities like leukopenia, thrombocytopenia, and a positive Coombs test.
Okay, let's address the big one, the classic fear. Cross-reactivity with penicillin. If a patient says they have a penicillin allergy, how worried should we be?
The good news is that the risk is far lower than we used to think, especially for patients who had, a mild rash from penicillin, not anaphylaxis. The data suggests only about 2% of penicillin-allergic patients will actually react to a cephalosporin.
And why does that risk change depending on which specific cephalosporin you pick?
It all comes down to the chemical structure, specifically something called the R1 side chain. It's the part of the molecule the immune system recognizes. If the R1 side chain on the cephalosporin looks a lot like the one on the penicillin, the risk is higher.
So if the shapes are different.
The risk becomes negligible. This is true for most third and fourth generation cephalosporins. Cefazolin, for example, has a very unique side chain and extremely low cross-reactivity. But you always have to be cautious if a patient has a history of a significant and anaphylactic reaction to any beta-lactam.
Okay. We also noted that Cefotin has a couple of very unique warnings. Let's start with the alcohol interaction.
Right. Cefotin has a specific chemical group on it that interferes with alcohol metabolism. If a patient drinks ethanol, they can get a pretty severe disulfiram-like reaction,
Yeah.
intense nausea, vomiting, flushing, headache.
And the second one is about blood clotting.
Correct. Cefotin can interfere with vitamin K, which can cause bleeding. It can elevate the PT, INR, and PTT. The good news is that this is reversible just by giving the patient some vitamin K.
What about use during pregnancy and breastfeeding?
During pregnancy, they're generally considered safe. There are no studies showing a risk to human fetuses. For breastfeeding, though, it's often discouraged. Not because they're dangerous, but because the cephalosporins can get into the breast milk and potentially alter the infant's gut microbiota.
Okay, we have to end on the most critical high alert warning in this entire class. The contraindication with 5-E ceftriaxone and calcium. This is non-negotiable.
This point cannot be stressed enough. 5-E ceftriaxone must never be co-administered with any calcium-containing 5-E solution, and that includes things like parenteral nutrition in neonates who are 28 days old or younger.
And why is that rule so absolute? What's the danger?
There have been tragic, fatal cases where the ceftriaxone and calcium formed a salt that precipitated out of solution. It created microcrystals that then got lodged in the lungs and kidneys of these babies. It's a catastrophic and completely avoidable event.
And does that warning extend beyond newborns?
It does. While the fatal cases were in neonates, the risk is theoretically there for anyone. So the general rule is that in any patient, you should not mix ceftriaxone and calcium solutions, or even give them within 48 hours of each other, even if you're using completely different IV lines.
Just keep them separate entirely.
Completely separate. And there's one more ceftriaxone warning for neonates related to jaundice.
Right?
Yes. It's also contraindicated in hyperbilirubinemic and preterm neonates. Ceftriaxone can actually kick bilirubin off of serum albumin. That free bilirubin can then cross the immature blood-brain barrier and cause kernicterus, which is devastating brain damage.
A truly terrifying scenario. It just underscores how critical these drug-specific warnings are.
It absolutely does.